the goal. Everyone, got to get out of here. Okay, great. Hi, everybody. Thank you so much for coming out tonight. It's not so cold, actually, right, compared to earlier this week. It's balmy here for Wisconsin. I'm Tiffany Mullen. I'm a functional medicine physician. I'm the CEO and co-founder of Vital Health, which I'll tell you a little bit at the end of this. I'll do a shameless plug at the end of this presentation. We're going to talk about long haul COVID. And I kind of wish we were talking about it like, wow, wasn't it wild, that COVID thing? And we got through that, and now we just have to talk about this topic. But obviously, we're still talking about COVID. I'm going to try to answer questions to the best of my ability. And I want you to ask questions throughout the presentation. I am going to put some time at the end, hopefully, if I can talk fast enough, for questions as well. But just understand there's a lot we don't know. There's a lot we're figuring out. We're sort of still in the beyond like 2 years of this, we still are trying to figure out so much about this disease. The other thing I want you to do is I want you to walk away from this talk tonight thinking about viruses in general, and thinking about fatigue in general, and thinking about other things that this has an application for, because we're talking about a concept of a virus, and we're talking about how the body responds and some of the things that we can do to help that, but it really extends beyond long haul. So if you think about yourself in a different context, or you know somebody in your mind who's struggling with another type of long, undiagnosed or fatigue type illness, some of these things might actually apply as well. So we're going to broaden it out a little bit in that way. Are we good? All right. Don't be shy. Speak up if you don't understand something, or if I'm talking too fast, or if I can. Is it this one, Dan, or this one? The top? Okay. Yeah, there we go. Okay, so what to expect. I once did a talk here, and I got all the way to the end, and somebody said, well, I don't know what functional medicine is. So I'm going to always start every talk with what is functional medicine. So we're all on the same page, and we all understand what functional medicine is, because that's the framework through which I, as a physician, see healthcare and see patient care. We're going to talk just very basically about COVID-19. We're going to talk about what the symptoms are, which you all know. We're going to talk about what this virus is, what it looks like, some of the statistics about where we are right now. And then we're going to move into talking about who gets long haul COVID, who are the people that get that problem, and what are the symptoms of that problem? What does that look like? We are going to talk about some of the hypotheses about why the symptoms occur, and why some people have long symptoms of COVID beyond when they're testing negative, and they're beyond that acute illness, and now they're moving into this stage where they don't have COVID anymore, but they still have symptoms. And then how do we diagnose it? How do we actually get at, does somebody have long haul? Is it from COVID? How do we figure that out? And how do we diagnose some of the symptoms that people are having? And then we're going to explore some options for treatment. And this is really where the functional medicine piece shines, because what I'm seeing out in the traditional medical community is people who get long haul, the traditional medical community is responding with long haul clinics, which are basically a center that they've developed in their healthcare structure. So, I've seen this at Northwestern, I've seen this at, organizations all over the country. And they're really more like referral hubs. So if somebody was severely ill with some lung issues with COVID, they're being referred to pulmonology, or they're being referred to a cardiologist, or they're being referred to different people to kind of deal with the symptoms. And that's the part about functional medicine that I like, is that instead of taking the patient and dividing them into organ groups and saying like, oh, lungs over here and heart over here and nervous system down here, what we're saying is there's some common denominators here about what's happening with people that we can address directly, and we need to be thinking about the whole person individually. So we'll talk about that, and then hopefully we'll have some time for Q&A. And I want to, got a feather on my coat. I want to get out of here at 7:30, right? Okay, Dan's going home at 7:30, so we could only talk so long. All right, so first, what's functional medicine? Oh, sure. Am I not talking loud? I feel like I'm shouting. No, you're not. Oh, okay. All right. I think that if anybody also starts to talk, if they start cowering, I'll know. Okay. So what is functional medicine? Functional medicine is the application of treating somebody with the idea that we're solving for root cause. So when we're looking at somebody and we're saying they have these set of symptoms, they feel this way, what's under that? What could be the reason why this situation's happening? That's not something that we do a lot of times in traditional healthcare in my church. I'm a family physician, so I practiced for 20 years. I practiced traditional medicine and still do in some ways. But instead of that sort of, you wake up one day and all of a sudden now you have heartburn, and you go to the doctor and the doctor says, here's your prescription for heartburn. Well, you didn't have heartburn the day before that. So what happened? Like what's the thing that's causing that to happen? And how do we get to treat that instead of just band-aiding the symptoms? Make sense to everybody? So that's kind of at the heart of functional medicine. We also go, when we're looking at symptoms, we go a lot deeper in evaluation. And part of that is that we're looking for root cause. We're not just going to settle for basic labs, and basic labs are fine. So it must be, well, I don't know what it is, or it must be, something in your head, or it must be something that, we have no reason for this, and here's how we're going to treat it. No, we're going to go down into all the layers of an individual, depending on what's going on with them, and figure out where are things going wrong. It gets very detailed. Doctors who practice functional medicine are very curious. We want to understand not just the biological part, but we want to understand the lifestyle. We want to understand what's happening in your life, what your personal values are, who is your family, how do you all influence each other, what is the timeline by which all of these things came to be. That's how we learn to think through this stuff in functional medicine. So it's a really great, wonderful, rewarding way to think about medicine. I've loved it all these years to practice this. It's wonderful. So we're very personalized in our approach. We're very prevention oriented. So as we get into why, then it's looking at the whole individual and how do we keep you from falling apart? How do I get into the place where I can sort of start to think about what might happen to you? And I'm going to get way upstream and I'm going to try to figure out why that might happen and put into place all the things that can prevent that. So instead of waiting for you to have a heart attack and you show up at the emergency room and now we have to put stents in you, how do we get way up ahead of that and stop that from happening? That's what I want for me, my family, all of you. We shouldn't wait till people are broken. I talked about nutrition and lifestyle. We take a lot longer. Initial visits are an hour. We really spend the time to understand things. It's not that revolving door thing. And we provide answers and get at the root cause instead of just, again, band-aiding the situation. So is everyone clear on functional medicine? It's better, right? No, I'm biased. Okay. All right, so let's talk about this coronavirus. It looks exactly like this. No, I'm kidding. This is the colorful version of it. So you probably you've read stuff about like coronavirus, and we've learned about these spike proteins and some of this other stuff. But in a nutshell, what any virus is a collection of sticky molecules. I think of these almost as like little places of Velcro, right, on the outside in this capsule. And then there's the outside envelope, and inside is some sort of material. In the case of coronavirus, this is RNA material. Instead of DNA, like genetics, full genetics, it's a part of the genetics that can be incorporated into your own genetics and sort of take over and drive how your genes are expressed. And that's why it's so powerful, and that's why it affects people. The other RNA virus that you probably all know about is HIV. HIV is an RNA virus as well. So there's a few of these RNA viruses that are around, not many. Most viruses are not RNA viruses. So it has a very specific way that it gets its way into the cell. It sort of hijacks the cell, takes over, and has, significant consequences. And that's part of why we understand how this virus works and how we can sort of get behind how to treat it. So some statistics. Oh, something happened. Something happened when I emailed you. Okay, that's okay. We can wing it. So as of, what was the 11th? Yesterday? Yeah, yes. Today the 12th? 2 days ago. I lose track of time. There were just shy of 62 million cases in the US, 311 million cases worldwide. This is 850,000 US deaths and 5.5 worldwide deaths. So this is nothing to sneeze at. This is a significant illness. I don't need to tell you this, but obviously we have a spike that's happening now. Lots and lots of increases in cases. This keeps going up every single day. Hopefully we're starting to peak out and we'll get on the other side of it soon. What are the symptoms? I think a lot of you know this already. Fever, cough, shortness of breath, trouble breathing. Fatigue is a really common symptom, both in acute illness, acute COVID, as well as long haul. We'll talk about that. chills, body aches, muscle aches, looks very much like flu, top to bottom aches, headache, sore throat, particularly with the Omicron variant. Sore throat has been a big symptom. Congestion or runny nose, loss of smell and taste, really pretty much related to this virus. Is the only virus that I can think of that causes that. Unless you get really stuffed up from like a cold, you can lose your sense of smell and taste. But this is a very specific coronavirus symptom. Nausea, vomiting, and diarrhea. So really looks like a viral syndrome, looks like flu, looks like a cold, bad cold, with a few little nuanced things that are specific to coronavirus and COVID-19. So when we start talking about long haul COVID, what is that exactly? So there's a couple of ways that this is referred to. So long haul COVID is one. It's also called long COVID, I dropped the haul part, or it's also called post-acute COVID syndrome, which is abbreviated PACS. And what it is it's persistent symptoms of some kind after a documented COVID-19 infection. So the key is that we need to know that COVID-19 is there or suspect that it was there. Ideally, a test would be great so that we know that we can link this problem to COVID-19 and then in the context of that understand it's not required. And there is no specific diagnostic criteria. There is not a set of things that says if you have this, 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 and this, or this and this and this, you have long haul. We just haven't gotten to that point yet where we can define it. So there isn't a way for us to sort of check that. There's also not one single test for long haul. So we don't, for example, we have a nasal swab for acute illness. We don't have a test for long haul. We just don't have it yet. So we have to rely on some other things to try to get at it, which we'll talk about in a minute. Everyone good? Okay, great. So what are the symptoms of long haul COVID? And if any of you have yourselves or had anybody in your lives that have had chronic fatigue syndrome or chronic viral reactivation problems, it starts to look pretty similar, right? This is when I said at the beginning of this talk, there are a lot of crossovers here. So start looking at it through that lens. Shortness of breath can persist in people, especially people who have pretty severe lung infections at the time that they have COVID or were on a ventilator, so on and so forth. The things that are in orange/red are the things that I've seen the most in the patients that I take care of with long haul. Fatigue, number one. Number one is people are tired and they cannot catch up on their fatigue. The fatigue is a very prominent symptom. Joint and muscle pain is also really common. Symptoms that get worse after physical or mental activities, which is also called post-exertional malaise, also really common. I can go to my work, but by the time I get home, I literally have to go to bed. I can't even make dinner. Like that's the level of fatigue. Or I can't even make it through the whole workday. I have to nap in the middle of the day. I have several patients like that. Difficulty or thinking or concentrating, which we think about as brain fog, really common with long haul, also with chronic fatigue syndrome. Cough, chest pain, abdominal pain, headache, fast beating or pounding heart. So you start to see some of these neurological symptoms. A heart's being run by the nervous system, right? So that the heartbeat increasing can be a symptom. Pins and needles sensations in various parts of the body. Diarrhea and other GI symptoms, sleep problems, both sleeping too much and not being able to sleep, or some combination of those two things. A persistent fever that kind of waxes and wanes can be a part of it. Dizziness or lightheadedness on standing. Various types of rashes or worsening of underlying skin conditions like psoriasis or eczema. Mood changes, depression, anxiety. Change in smell or taste can persist, and then even changes in menstrual cycles. I've had several women who didn't necessarily have a lot of the post-COVID symptoms, but have gone on to have really funky menstrual symptoms. And there's actually a study going on looking at that. They're also looking at menstrual symptom changes after the vaccination, which is really interesting. Like, wow, that's kind of fascinating. I'm not really sure why, but so how prevalent is it? How many people get long haul after they've had COVID? So it's somewhere in the realm of 50 to 87% of people who contract COVID-19 report some kind of symptoms, some really, yes, right, really high. Some, mild and some pretty severe up to 2-3 months. And that's as far out as we've really studied this, as we don't really have a lot of data. I personally have a patient who's had it for a year, but we don't really know what the average amount of time that people have symptoms afterwards. There was a study that was done in June of 2021 that was a survey, asked about 1.9 million people who knew that they had a COVID positive somewhere between February and December, so pretty early before vaccination status. And they were tracked a whole year. And about 23% of them reported persistent symptoms more than 30 days. So that's a little bit of a smaller subset. And it was fatigue that was the symptom that they reported most in that group. So it's not uncommon. It's not uncommon, I think, is what I want you to walk away with. Not that I want you to live in fear of that, but I think it should just be very motivating for people to take this seriously and not, try not to get COVID so that this doesn't happen. I get asked all the time, does getting long haul relate to the severity of the disease? So if I have a very severe case, am I more likely to get long haul? Or if I have a very mild case, am I less likely to get a long haul? Actually, no, both get it. The people who have severe disease seem to have a higher prevalence, but most of those people are probably dealing with, very severe attacks on organs. So they are the people that have the persistent shortness of breath because they were on a ventilator, or they had severe pneumonia, or their lungs were affected, or their heart was affected, or their kidneys were affected. But the asymptomatic, mild to moderate case, so the people who don't end up in the hospital, tested positive but had no symptoms, about almost 40% of those people develop long haul. And their symptoms look a little bit different. They tend to look like fatigue, muscle pain, and weakness in that brain fog. So a little bit of a different kind of picture with people who are mild to moderate. So you don't have to get very sick to develop this problem, I think is the bottom line. So what causes,
So when you stated that,
Mhm.
it's asymptomatic, mild, or
Moderate.
moderate,
Mm-hmm.
what do you mean by that when you're saying asymptomatic, but you're talking about the symptoms?
Asymptomatic, so somebody who's asymptomatic and who's diagnosed with COVID is somebody who's like, I have absolutely no symptoms, but I went in for a test because I got exposed or something to that nature. Positive swab, I feel fine, I have nothing wrong. That person is the asymptomatic. Does that make sense?
So do any of those relate to improper false positive?
So could somebody have a false positive?
Asymptomatic.
Sure. Oh, absolutely. Yeah, you can have false
So we don't
positives.
really have.
Yeah, I mean, this is as good a data as we have. Yeah, there are false positives, obviously, that happen. There are more false negatives that happen. But yeah, that it's really hard when people are asymptomatic to try to figure out like who has long haul. But if they had a positive test, it's really great for us to at least try to understand that subset of people better. What causes long haul COVID symptoms is really all about our immune system response. So we're going to get into this. And I put this diagram up here specifically because I think a lot of people, when they think of the immune system, they tend to think of like white cells circulating around in the body. But the immune system is everywhere. So we have these types of cells that protect us, right? The T cells, the B cells, all these cells that are in our bloodstream. And our bone marrow is active when we talk about immunity. Our gut has 70% of our immune system in it. Our brain and our kidney and our adrenal glands and all, our nervous system all have tissue that's associated with it that's immune tissue. So that's why this is so widespread, and that's why people become sick the way any virus, but it doesn't just attack the immune system, it attacks all of the immune system and all of the body parts. So what are the theories? And I alluded to this when I did the introduction. We're talking about hypotheses. We don't know for sure yet what is causing long haul in people, but there's some ideas about it, and we'll talk about these individually. One is this idea that was developed by Dr. Iwasaki in that people who clear the infection, in other words, I swab their nose and they don't come back positive, but they're still circulating virus on some level, or they're circulating little tiny fragments of the virus that are still enough to activate the immune system and keep this going, right? We call those viral ghosts. I'd never heard of that before, by the way, until I learned about this disease. So there's this inflammation and chronic stimulation of the immune system that's happening on some level. That's one hypothesis. Another hypothesis is that there is reactivation of viruses that we have in our body already: Epstein-Barr virus, herpes viruses, potentially varicella, things that we've had in the past that then become fired up with this type of disease. The lung and gut microbiome have probably a big role in who gets COVID in the first place, but also who gets long haul and what happens to them. And then the last is this mitochondrial dysfunction. We're going to talk about what a mitochondria is. This is a really important concept, I think, for everyone to think through. So let's dig into each of these individually, because I think it's good to understand them. If we talk about persistent immune activation, and I'm not going to give you an immunology lecture because that would take all night, but it's this idea that there are these viral particles, and I like, this one looked like it had little flowers on it. Can you see that? So I made these little ghost guys, and they have masks on, which I thought was appropriate. So there's a virus or some particle of a virus that's infecting a healthy cell, causing this whole cascade of immune response. This is how we do things. We have a B cell that finds it. It makes these inflammatory molecules called cytokines. You've probably heard of cytokine storm, right? That's the big part of why people get so ill from COVID. That's the cytokines. And then activation of those B cells to create memory response, and then ultimately antibodies so that we can fight it if we see it again. So it's this immune response that gets completely crazy and keeps going around and around and around. The other idea that Dr. Awasaki had was, is there immune reaction to parts of the virus, so the spike protein or the nucleoprotein, that stuff inside, that's cross-reacting with certain antibodies and certain weak spots that we already have. So if you have an autoimmune disease, for example, you have Hashimoto's, or you have rheumatoid arthritis, or you have some autoimmune disease, maybe you don't even know it, that you have that. Could there be some sort of firing up of that autoimmune disease as a result of this? We think that probably most autoimmune diseases have a viral trigger at some point, probably also a genetic predisposition, but we think it's that viral trigger that a lot of times starts the autoimmune process across the board. So if you look at that, any of the antibodies that you could potentially make could impact pretty much any part of the body. You could develop eczema or psoriasis, you could develop gut problems, nervous system problems, certainly thyroid, joint like rheumatoid arthritis. Everything could potentially be activated by these cross-active immunoglobulins or antibodies. We good? Not losing you, right? Okay, cool. All right. What about reactivation of dormant viruses? This is one of the theories around what we think chronic fatigue syndrome is. We don't know that either. But that there are these viruses that we live with all the time that are in us or parts of us, and that they can get reactivated when we get sick because the immune system starts stimulating and then the immune system goes awry. So Epstein-Barr virus, mono, everyone's heard of that one, right? Human herpes virus 6, really, really common one. We don't have a lot of Ross River, thankfully. We don't have a lot of Ebola here, but those are things that can be reactivated. Enteroviruses are primarily gut ones. West Nile, dengue fever, parvovirus we see a lot of. That tends to be in kids, but adults can get it, and it looks like an arthritis when adults get it. So reactivation of these dormant viruses can potentially cause people to have an acute case of COVID, and now they're starting to look like this person who never gets well. What does the gut microbiome have to do with this? So does everyone know what the microbiome is? Are you all familiar with that term? No. So it's the collection of bacteria in our colon, our good bacteria. The other word that we use is flora, our flora. Okay, so that's the microbiome. Really important, guys. They're really, really important to our health and our immune system because they're sitting at the face between the inside of us, which is contiguous with the environment, and 70% of the immune system, as I mentioned earlier. So there's an interface that's happening between the gut and those bacteria that are helping us, and then the immune system on the inside. So the way that your gut microbiome or flora looks like is really key. When they study this, they're looking at people who have dysbiosis, which is a word that means a lot of bacteria in the gut that aren't very healthy, the kind that proliferate with bad diets and poor attention to health. Those people tend to be more at risk for COVID, and they tend to have worsening cases of COVID. So there's a really good study that looked at, actually several studies that looked at that, the association between the gut microbiome and who gets sick and how sick they get. But then on top of that, we've been able to identify a couple of bacteria this Faecalibacterium prunesatii, which I love, and then Eubacterium rectale, which are, when they're low, we are more at risk for developing long haul. So we've actually been able to look at stool of people who have long haul and make this association, several bifidobacteria as well. So it's this unhealthy gut maybe that's causing part of the reason why people can't clear this disease. They can't get better. So let's start off with, we're going to talk about mitochondria, but I want to talk about what mitochondria is first, because most people are like, I've heard of that, but I'm not really sure what it is. So I want to make sure that everyone's on the same page. So a mitochondria inside of a cell is this little guy, it's a little organelle inside the cell that's whole job is to make energy. So all it does is, and not all it does because it's important, but it makes this, what I call the cellular battery run. So it's making this material called ATP, and ATP is the currency by which our entire body works. It's how we are upright, is how we're alive. We make ATP. Every cell makes them. Some cells have more mitochondria than others, but we're talking about thousands of mitochondria, and they're all just cranking ATP out. Okay, that's all they do. So that's what a mitochondria is. It's kind of like the Ferrari of the body. It's like driving all the machinery, making everything work. Okay, that's what a mitochondria is. I want to divert off the mitochondria just for a minute because I want to talk about chronic fatigue syndrome. And again, I'm sort of making these links between long haul and chronic fatigue syndrome because we've learned a lot about how people become chronically ill after a virus by studying chronic fatigue syndrome all these years, especially in functional medicine. So in functional medicine, we were always the ones that said, I believe you that you have chronic fatigue syndrome, and I don't think it's depression, and I'm not going to offer you Prozac for it. So we have had a lot of experience. Now, that doesn't mean that we have it all figured out. We still don't exactly know, especially probably there's many different ways that chronic fatigue presents. But what I think is so interesting is that instead of trying to figure out the why and put a lot of energy into that, we've put a lot of time into naming it. So we've gone from epidemic neuromyasthenia back in the 30s to benign myalgic encephalomyelitis. Benign doesn't sound very good. I mean, it's not very benign. It just meant like, oh, it doesn't kill you. That's about all. Then myalgia nervosa, which makes me really upset because it's like, well, that really sounds like it's in your head, you know, post-viral fatigue. And then we started to get some diagnostic criteria in the mid 80s for this myalgic encephalomyelitis. The benign was dropped. And then finally, we sort of have this ME/chronic fatigue syndrome together. There's even a proposed in 2015, they wanted to call it systemic exertional intolerance disease. So, I mean, by the time all these organizations get around to naming these things, we could have, done a lot better. And then they set out criteria. So there are criteria for chronic fatigue syndrome. You have to have fatigue and debilitation for more than 6 months, post-exertional malaise, which you guys all know what that is now, unrefreshing sleep, got to have all those. And then you have to have at least one cognitive impairment or orthostatic intolerance. What is orthostatic intolerance? You get up quickly and you hit the deck or you feel lightheaded. It's that sort of sympathetic nervous system stuff that people have. So one of those. So as we move forward with long haul, it'll be really interesting to see whether we start borrowing some of this stuff, whether it'll start to have this kind of a story where we're going to name it a whole bunch of different times, or we're going to develop criteria for it, or what this is going to look like going forward. The name it, tame it, blame it disease thing. All right, so let's go back to mitochondrial function. Okay, so what we think happens with COVID-19 is that I showed you the picture of that. Ooh, what did I do? Oh, Dan, help me. I hit a button. What we think happens is that the genetic RNA material inside the cell, what did I do? Oh, how did I do that? Oh, great. That was easy. Thank you. Okay, sorry. Sometimes this thing has a lot of buttons on it. Throws me. Okay, so what we think happens is that there's a cell, the cell that has a nice wall around it. Here comes this COVID-19 molecule that has those spike proteins on it. It hinges onto the cell, injects its RNA material, and where that RNA material ends up and what kind of cell it is determines the symptoms, right? So if it goes to a cell that has a lot of mitochondria in it, think muscle cells, think brain cells, think heart, consuming a lot of energy, right? Right now, You guys are burning through ATP, just having your heartbeat, just thinking, listening to me. ATP is being consumed. These are high energy requiring parts of the body. So if those cells get hijacked and they inject their RNA material into the mitochondria or into the cell and tell the mitochondria, you just take a break, we got this, you can imagine what would happen to the cell, right? Mitochondria powers down, and all of a sudden, why do I feel like I ran 10 miles? Like I have no energy in my muscles. Why can't I think? I can't remember my own name. Why am I so tired all the time? Right? Mitochondria is behind that. That's a big part of what we think is going on here. So it's using the mitochondria, and it's also, meanwhile, causing that mitochondria to create even more what we call reactive oxygen species. These are you take antioxidants like beta carotene and vitamin C, right? Antioxidants are taken and eaten because there's oxidation happening in the creation of ATP all the time. That's a normal thing. If this theory is true, the virus is creating even more oxidative damage. So there's even more damage on the inside of the cell, which then causes the cell to die. And as I said, the mitochondria are concentrated in parts of the body that require a lot of energy. Think nervous system, muscle, heart, lungs, things that are going all the time. Nervous system, not just the nervous system like sensory nervous system, but also people who develop that thing where they stand up and they're dizzy, or their heart beats too much when they're they shouldn't be having their heartbeat. I hear that from some patients too. That's the sympathetic nervous system. So in the same way that chronic fatigue syndrome or encephalitis, myalgic encephalitis, there is this neuroinflammation that we think is happening as well. And this is this is one of the things that actually happens in the body when you're sick. So when you're sick, the last thing that you want to do is get up and move around, right? You want to go lay down. That is actually by design. We want to go lay down and rest because we need to conserve energy to fight the infection, right? So there's this thing called a fatigue nucleus inside of the nervous system that creates these signaling molecules, cytokines, that tell us to go lay down and rest. That's part of how we're designed. That's part of why you feel, tired when you're ill. It's to conserve energy. And if we are constantly fighting that, we could be triggering this fatigue nucleus, and that might be part of the reason why we feel the way that we do. And then we talked about that impaired energy production through the mitochondria, which you all are experts on, mitochondria now, oxidative stress, creation of all these molecules inside of the cell that's poking holes in it and making it not healthy, but also potentially decreased blood flow to the brain. One of the things that COVID-19 can do is actually inject itself into the cell and dial up clotting factors. So you've heard a lot about people getting microclots during this, strokes, things like that. That's part of the way that this virus causes its problems, is it actually dials up the clotting cascade inside the body. So decreased blood flow. So what do we do when we're testing for long haul? Now, this is not testing for acute disease. This is not the PCR and all the stuff you guys all know and probably have had more than once. This is testing. What can we look at when somebody's coming to me or thinks that they may have long haul? What are some of the clues that I can look at to help me make this diagnosis? Knowing, again, that there is not a single test. There's not a long haul panel or a long haul test that I can check on my labs sheet. That doesn't exist. So what else can we look at? We can evaluate a complete blood count, what's called a CBC. Looks at our white cells and our red cells and our clotting cells. Sometimes that'll tell a story. The way that the white cells lay out looks very viral. Lymphocytes are high. So I use that CBC. Inflammation tests we can use. This is all blood work. C-reactive protein, if you've heard of that, or a CRP, SED rate, or ESR. We can look at ferritin. Ferritin's really interesting because it's the storage form of iron in the body. It's how we store iron, but it's also an inflammatory marker. When it's elevated and somebody's sick, ferritin goes up. And then we can look at lactose dehydrogenase, which is another marker. We can also look at D-dimer, which is associated with that clotting. So there's a bunch of things that we can look at that help us know whether there's inflammation happening. Sometimes it's very obvious, but sometimes it's not, and so we look at that. We can actually also study T lymphocytes, a certain kind of immune cell, something called a CD8. We look at that when people have HIV as well. And natural killer T cells, that are abbreviated NKT, are pretty specific for this virus. So if we're able to look at, and this person has an elevated NKT count, it's probably going to be a COVID-related issue. We look at autoimmune markers as well, antinuclear antibody, ANA, which is typically associated with things like lupus or rheumatoid arthritis, and then antiphospholipid and anticardiolipin antibodies, which are traditionally associated with clotting disorders, autoimmune clotting disorders. For patients who have that dizziness where they stand up or their heart's pounding, something we call postural orthostatic tachycardic syndrome, or POTS. Have you guys heard of POTS syndrome? Yeah. Autoimmune dysautonomia panel can be done. And then we can look at this anti-ADRA1A receptor. I don't expect any of you to remember this. There will not be a quiz. I just wanted to be very, very comprehensive in listing out the things that can be evaluated. We can look at oxidative stress markers with ADHDG, and I'm not going to tell you what that is because I don't remember, but it is something that can be done off of urine. And then obviously we can look at the gut microbiome. If we think that the gut is maybe a place that could use a little dusting up, we can look at the microbiome. We can actually quantify that and then get in, treat infections and so on. We're going to talk about how we treat in just a minute. So there's no specific COVID test. There's not a long haul thing, but we can look at things and start to see in an individual patient, it's inflammation that's causing this. Oh, you have an autoimmune thing that's been triggered. Oh, you still have a lot of viral stuff that's happening with natural killer T cells. You might have, have developed some autoimmune stuff around your nervous system. So we can start to peel away for an individual patient with a given set of symptoms, what might be going on underneath them. We're going to talk about treatment next, and we're going to talk about three areas. We're going to talk about immune balance, so things that are anti-inflammatory, antioxidative, and antiviral, killing virus, making oxidation better, decreasing inflammation, treating the gut, and then we're going to talk about how do we get those mitochondria to work better. How are we doing? How are we doing, Dan? Oh, we're going to do it. Okay. All right, so, okay, got it. Okay, so treatment options. Of course, because I'm a functional medicine doctor, I'm going to actually not talk about medications. You can use medication to treat people's symptoms, obviously. I'm not going to go down the, ivermectin, Luvox controversial thing, because that really doesn't have much evidence in long haul. We could get into it around acute treatment, but I'm not going to because Dan needs to get home at 7:30. I'm sidestepping all the controversy, obviously. So what can we use in this realm? Anti-inflammatory, antioxidative, antiviral. We can use high-dose IV vitamin C, 25 to 50 grams, a lot. You can't even swallow all that if you tried. You could maybe take 5 or 10, but man, that would be tough on your belly. So IV vitamin C, liposomal glutathione. Liposomal is bolded because all glutathione is not the same. Liposomal is better absorbed, okay? It gets into the body easier. Glutathione is a potent antioxidant, master antioxidant, sitting right there in the ATP, just mopping up all the oxidative damage. You can do that IV as well, but you could also do it orally, 500 to 1,000. You can use anti-inflammatory medicinal mushrooms like cordyceps or reishi. Vitamin A, which is an antioxidant, vitamin D3. Can I say enough about vitamin D3? People who have low vitamin D3 are at risk for getting COVID, at risk for getting worse COVID, and I can't say enough. Everyone should be on vitamin D. And test if you're not sure what dose. And acetylcysteine, which ultimately makes glutathione, but another way to do it. Curcumin, turmeric, you've heard of that probably, that wonderful spice that we use in curry. Can't really eat enough of it, but 1,000 milligrams 3 times a day, really high dose anti-inflammatory effect. Liposomal, again, quercetin. Quercetin kills viruses. It's an amazing antiviral compound. It's present in onions and apples and all kinds of things, but you can take it as a supplement as well, and you do need to take it because if you're going to treat, because it's so hard to get that much in food. Green tea extract green tea has a lot of compounds in it that are anti-inflammatory. Andrographis paniculata, which is an herb, as well as Euthrococcus senticosus, which are really more sort of adrenal support, but also have impact on the immune system. And then olive leaf extract. Olive leaf is great. It treats viruses, it treats bacteria, it treats fungi. It's a really great all-purpose kind of anti-infective. I use it for all kinds of things. There's more. I mean, we could go on for days on this list. There's tons and tons of more herbals that are antiviral, antibacterial, but at least you kind of get a sense of like what we're talking about here, right? Anti-inflammatory, antiviral, etc. If we're going to go after the gut, and I do it anyway because the gut's so important, we talk about this 5R approach, okay? First, we remove things that are bothering your gut. We take out foods. If we don't know what they are, we test for it, see if there's foods that are bothering you. And if there's infections, like a bacterial infection or a parasite or candida in the gut, we treat that. So we get those out of the way. We replace things that are deficient, like digestive enzymes, bile salts, betaine, if you have low stomach acid, and we can test for all of this, so we don't have to guess. We re-inoculate with probiotics, right? Our wonderful probiotics and our prebiotics, which can be either done in supplement or food. Then we repair the gut lining, which has been sort of mad at you for having such a bad microbiome. Zinc, antioxidants like ACE. Oops, I forgot my parentheses, or maybe it got cut off. I don't know. Omega-3 fatty acids, fish oil, but can also be done vegetarian and kosher. Glutamine is wonderful for gut repair. Glutamine, glutamine, glutamine. And then rebalancing with things like sleeping well and managing stress. And it goes without saying that eating well is obviously what the gut wants. And what does well mean? Well, it's different for every person, but we all know what food is and what food isn't. I mean, you guys are all smart. I'm sure you know that. Okay. All right. So what about that mitochondria? What if we want to treat the mitochondria, make that better? How can we do that? So intermittent fasting, believe it or not. I don't do a lot of intermittent fasting with my long haul patients because they're already pretty depleted, but intermittent fasting is really well studied, and it actually does do an amazing job at supporting mitochondria. It actually has good studies on autoimmunity, specifically rheumatoid arthritis. So intermittent fasting is one way to positively impact mitochondrial function. So is CoQ10, 100 to 500. Mitoquinol mesylate, which is another supplement that you can use. PQQ, I just like to call it PQQ because I don't want to pronounce that. Magnesium glycinate, where a lot of us are magnesium deficient. Alpha lipoic acid, ALA. Acetyl L-carnitine, nicotinamide riboside, really, really great for mitochondrial function, and urolithin A. So these are all very supportive of mitochondria. So are your basic antioxidants, your A's, your B's. Those are all part of the ATP process, cofactors, healthy diet, rest, all that kind of stuff. And there's a product I think you have here, Dan, that's called Synapsin. Yeah, that has a nicotinamide riboside, and it also has an ingredient called ginsenoside, RG3, which Monica, the other pharmacist here, taught me is another really great way to support mitochondria. And I think you guys use it a lot for like neurological stuff. Yeah. So it has crossover to other issues. It's not just for long haul. So take a picture. This is good. Mitochondrial function, everything. When you're not feeling well or when you have fatigue. Yep. Should I pose? No. This is good. Yeah.
How long do you have to do that fasting for it to be intermittent?
Well, there's various approaches. So you probably heard of some that are just the 12 hours. There's the 1 to 3 days. I don't generally recommend run long ones. Like I don't like the 7 to 10 to 15 to 12, 2 weeks. That's a little bit like too stressful on the body. But it can be one day of really low calorie eating, like 500 to 1,000 calories, 500 to 800 calories, and then a day of not, and then a regular day, and then kind of circulating through. There's no one intermittent fast. There's lots of different ways. And the fasting mimicking, I think, is the easiest thing to do, which is just don't eat for 12 hours a day. That's pretty easy to do. And well studied, really well studied.
So Synapsin available as a supplement?
Yes. Yeah. Oh, Synapsin's prescription? Oh, is it? Really? Oh, okay, never mind. Oh, okay. Well, it's a prescription. I thought it was a supplement. That's interesting. All right. So let's talk about the COVID-19 vaccination for long haul. We're not talking about for acute. You can stand wherever you want. I'm not going to argue with you. I'm vaccinated. When we looked at 473 people with long haul COVID who got that first vaccine, now this was ways ago before everyone was, well into this. Most of them felt moderately unwell for a couple of days. And then about half of them, 46% of them didn't feel any different as time went on. 14% felt slightly worse than before the vaccine, but 36% of them completely got better. Boom, gone, long haul gone. So really interesting to get the immune system finally doing what it's supposed to do in this case was enough for about 36% of people, excuse me. So that's kind of fascinating, right? And obviously we're going to be studying this as time goes on. For people who had breakthrough infections, in other words, they were vaccinated, had a breakthrough infection, there was a 50% decrease in developing long haul if they were vaccinated. So there's some long haul related reasons to think about that. Other treatments that we want to think about. So we talked a lot about supplements. We talked a lot about things to swallow and take. But we also want to talk about lifestyle. When you have long haul, you can't go from Thursday, I feel terrible, to Monday, I'm going to go back to my 5K. You really need to take it slow. You need to return to exercise very, very, very slowly. So what that might look like is you might just start off with deep breathing as your approach, and then maybe some gentle yoga, and then some walking, and then higher intensity. And how do you know when to move? When you can tolerate it. And everybody's different. So there is no prescription here around how to move forward with exercise. But it is important that people don't go out of the gate. I've had that happen. Oh, I feel better. They go down. You really have to let your body recover. In my patient population, I have used acupuncture quite a bit, and it's been very helpful for muscle pain. Some fatigue, headaches really respond nicely. And then if people have neuropathy, the sort of pins and needles sensation in their extremities, that can be helpful as well. Physical therapy also I've had some good luck with, where the physical therapist is helping the person return to function, help them get better, help them decide how to move up in their exercise, keep them limber, et cetera. And then if they have a lot of those postural symptoms where they're dizzy and they have a lot of lightheadedness, really working on that as well. So physical and occupational therapy can be really helpful. We haven't talked a lot about diet, which obviously belongs in this category as well, but good nutrition, healthy, removing the stuff that's not good for you, and you all know what it is, so that your body can optimize and use your resources, have your gut microbiome respond positively and be healthy. So in summary, haha, Dan, look at that. Long haul COVID can occur with both mild, even asymptomatic, and severe disease. So it doesn't mean if you're a severe case that you're more likely, you're slightly more likely, but that you're the only ones that are getting a long haul. Where we can use lab tests to direct our care. So instead of referring you to the cardiologist for this and referring you to the pulmonologist for that, what if we really started to break down where the problems are? Is it inflammation? Is it viral? Is it gut? Is it where are you being attacked? And then focus on that. So we can use labs to help with it, but there's no single test. Treatment focuses on treating the underlying cause, whether that's dysbiosis in the gut, it's mitochondrial dysfunction, it's immune activation, it's development of an autoimmune disease. We can then, once we know what we're dealing with, we can target that. Vaccination can treat, as we talked about, in other words, make it go away, and it can prevent long haul. And functional medicine can make a difference. I've had some really, really good outcomes with some patients who, interestingly, the majority of the patients that I've seen have been doctors who were diagnosed really early, who were seeing patients on the front line. And before we knew what it was, and before we knew to wear masks and all of that, these doctors got sick. So shameless plug for Vital Health. We are a functional medicine group, a bunch of us. We're completely online. We have no clinic. We see everyone via video, so you don't have to leave your house, which is great. So from the comfort of home, you can see us there. We're a whole bunch of doctors across the country. We're not just here in Wisconsin. My doctors are everywhere. We see patients in about 34 states right now. And so that means that the doctor who's best for you doesn't necessarily have to be one that's in your neighborhood, which is always really nice. Thank you very much. Okay. Whew. So ask questions if there are any, and I'll do my best to try to answer. Yes.
So when you talk about vaccination, we've heard it with a lot of the functional medicine doctors that, the long haul of vaccination, they don't know about